Welcome everybody to the MGHBrain PBM clinic round. So today is November 12th, 2021. It's my great pleasure to welcome Marvin Berman, President and founder of the Quietmind Foundation, who is going to talk about photobiomodulation for neurodegenerative disorders. Marvin, please take it away.
Okay. Thank you. It's obviously an honor and a pleasure to be here and sharing with you. I looked up on PubMed before we started today the number of citations in the literature for low-level laser therapy. And from 1975 till 2016, there were 4,500 citations. And from 2016 until today, there are 3,381. And when I looked up photobiomodulation, the same time period, there were 322 from 1975 to 2016. And from 2016 till today, there are over 1,600 publications. So it's great to see that this whole way of thinking and looking at what we're doing with photobiomodulation is taking off and gaining popularity and gaining recognition. And the foundation started initially as a way to promote the scientific validity and efficacy of brainwave biofeedback training. So let me get my cursor where it belongs. So I just want to cover my conflict is that I'm now a principal with Neuronic Medical Devices, which is based in Munich and has offices in Galway as well. And I'm responsible for product and program research and development. But Quietmind is a 501c3 nonprofit charitable organization based in Pennsylvania. And we basically are a neuroscience research and clinical consultation practice. And since COVID, we've basically closed our private practice and are basically focused on clinical consultation. The mission of the foundation was really to support the generation of really high quality evidence validating non-invasive, non-drug treatment options and their integration into public health and also into education and training. And the consultation that we've been doing with clinicians and researchers really looks at, what is investigation and integrating the whole idea of digital neurotherapeutic applications. We, again, focused on neurofeedback, which was brainwave biofeedback training. And, we were looking at neurology's data then of what happens to people as they progress in dementia. And there was a very clear trend in their literature about the increasing of slow wave activity and the decreasing of fast wave amplitudes in the EEG and a decrease in the peak alpha amplitudes. So when I looked for how they were then translating that into practice and treatment, it became quite clear that there was nothing and that that's not what they were after. And so what it became our responsibility, frankly, was to take their data and then use neurofeedback to see whether we could, in fact, modify brainwave activity and have that result in an improvement in people's cognitive functioning. And so we presented in 2009 in Vienna on the use of brainwave biofeedback training, both in the clinic and also at home. So we had half of the subjects being treated, if you want to call it trained, by their caregivers in their house. And we set them up to do that. But we showed that there was no difference in the results, whether they came to the clinic or whether they did it at home, in terms of those people who were able to improve in the reduction of slow wave amplitudes, right? They were able to then correspondingly improve on the neuropsych measures. And when they decreased the slow wave amplitudes, they were also able to increase the mid-range alpha and SMR, sensory motor rhythm, low beta activity. And those people who were able to do that significantly improved on a number of different neuropsych measures. However, and it's a big however, we didn't really treat the underlying disease process. We were making an attempt to improve on what there was left. And we were changing the slope of decline, but we weren't really intervening on the disease process, which really was a neuroinflammatory process. And that's not what neurofeedback addresses. So I got involved in the photobiomodulation world by seeing an advertisement in the Daily Mail that was sent to me by the husband of one of the people in our study. And it basically was Gordon Dougal's study in the Daily Mail that he and Paul Cassano were doing back then about the mice who were treated with photobiomodulation and then put in the radial arm maze. And it said, researchers reverse dementia using infrared light. And I was like, oh my God, I don't think that's real. But then I read the paper and realized that it was real. So we asked Dr. Dougal to come to Philadelphia and bring a device and use it with this particular patient. And over the course of about 3 weeks, we started to see that in fact, something was happening. And I won't go into the whole story, but it led us to really recognizing that there was a dual process that needed to be engaged in, where we were both intervening on a tissue level with the photobiomodulation, but also then able to correct the neural connectivity with the neurofeedback. And that's kind of where we've been at ever since. I think that given who I'm seeing on the screen, I don't really need to be going into this, but we're really working on trying to understand more and more the underlying mechanisms of action. Clearly, there are very real multiple mechanisms at different levels of observation. And I like this slide because it covers a lot of the different levels and how they work and what it is that we're seeing as a result of photobiomodulation in terms of reducing inflammation, increasing blood flow, increasing tensile expansion of microcapillaries and angiogenesis. All of those different features are now becoming clear. I'm also getting interested in the antioxidant and the reductant balance, and we're looking at how to do something with supplementation along those lines, but we don't have anything published as yet. So where we've come down is that the main mechanisms have to do with, the heat-gated ion channels and modulating transcription, the neuroprotective heat shock protein changes and the growth factors, alteration of nitric oxide and ROS, the increasing cortical and free-floating ATP synthesis, and also the endothelial flexibility so that we're seeing that microcapillary expansion. But what I wanted to add was the ability of the photobiomodulation to literally entrain specific EEG amplitudes and to therefore be able to modify neural connectivity, which is referred to as coherence in the neurofeedback literature. So our way of thinking about photobiomodulation is basically, using the light energy to heal and regenerate and protect tissue. But then there's even the possibility that light therapy can be used with cognitive enhancement in normal, healthy people. And that paper, which just came out and the BBC covered it, and there was a lot of splash about 2 weeks ago, wasn't it, James? That we saw a big presentation in the media in the UK about a small pilot study that was done at Durham using the Dougal helmet.
Yeah.
And they worked with normal subjects and they showed a 20% increase in memory, a significant improvement in digit flexibility and motor processing, and also in terms of cognitive performance speed. So it lends itself to the idea now that we can start talking about how you can use photobiomodulation preventatively as well as therapeutically. But from our end, we really had to start from the other side and talk about how we can treat before we can start talking about how we can prevent. But I think now the time's coming where we can start making that a more coherent argument. Where we're at now is thinking about biophoton intensity and looking at it from somewhat of a quantum biology point of view, and that's got a lot of interest in our scientific advisory group. And Jack Tuszynski is someone who we've been paying attention to for a long time, and he's a colleague of mine. And I think that this whole idea of EEG synchronization and phase lock and phase reset in terms of interhemispheric coherence really expresses some aspects of the biophoton field state, and that what we're trying to do with photobiomodulation then is kind of facilitating the EEG coherence normalization for sure, but we're also supporting that neural reparative anti-apoptotic function and what may turn out to be the biophoton field functionality. And that gets into all of the activity that photobiomodulation seems to have on the microtubule activity. But that's a talk for another time when I have more of my brain available. This is the paper that we published about the use of the Dougal helmet with a multi-site, double-blind, placebo-controlled, randomized population of about 100 subjects. And we looked at the use of the helmet, but we were giving the helmet to the people to take home and use twice a day, every day for 2 months. They got a baseline assessment of a quantitative EEG, and they also got the full ADAS-Cog battery. And then they came back a month later and got a different variation of the ADAS-Cog and the QEEG. And then they came back at the closure and got a third version of the ADAS-Cog and the QEEG. And we're working on that data now, and we'll have a publication, I hope, in press in the next month or so about the whole 100 subjects. At the moment, we only have the Texas cohort, but we use this is the Dougal device. And the penetration issues have been covered. Paul Chazot and Steph Grillo and the people at Durham have done the work on that and shown that there can be between 3 and 5 centimeters into the cortex, depending on the power delivered to the scalp surface. And that primarily the loss from scatter is really coming from the hair and the skin and not from the bone. As far as the choice about 1070, well, we saw that the 800 penetration was the best, 800-ish, but then we saw this big jump back up at 1070, 1065 to 1075, and wanted to really look at what was that about. And Chazot and his group has really been looking at that. And I think that they've come out with some very interesting results in terms of BDNF and molecular activity and apoptotic activity and heat shock protein behavior. There's a lot of material there that can be looked at. This year we presented the findings from the Texas study at the AAIC meeting. And I think that's, Paolo saw this presentation, and that's what got it. He invited me to give this talk. So essentially what we came out with was a significant difference in the mini-mental status exam, where the difference between control and active was rather significant. And we saw people going from impaired to in mild cognitive impairment. Some people went as high as 7 points in improvement from 2 months of stimulation twice a day. This is a sample of clock drawing that we saw in the ADAS-Cog. And when we started looking at the quantitative EEG, this is an aggregate of the 48 subjects that we used. We had trouble with some of the other data, but I think there was about 48 subjects that went into the comparison here, and the aggregate microvolt change which we were looking at because of that issue of slow wave amplitude increase. We wanted to see, did the slow wave amplitudes decrease? And where you see the blue is the post minus pre data, and it's showing significant decreases in the slow wave amplitudes, both in the occipital parietal on the left and significantly on the right in theta, and more in the frontal and prefrontal in delta. This was what we expected to see based on the earlier data in the neurofeedback study. But now we're seeing that photobiomodulation alone was able to produce very similar results to the neurofeedback in terms of amplitude, slow wave amplitude reduction. And here we're talking about the absolute power group mean change pre-treatment to post-treatment. And what you're seeing is the significant red areas were above normal in delta, and you're seeing a significant reduction in the delta overactivity and an increase in the normal, which is the green activity in the population that received the active treatment. I'm particularly interested in the sensory motor rhythm because it's been associated with a state of relaxed attention, and that optimal being in the zone focus seems to have something to do with the ability to sustain that sensory motor rhythm activity. And we've seen that when you increase sensory motor activity and decrease the slow wave activity in children and adults with attention deficit disorder and depression, you see that there's a significant improvement in their symptoms. But here we saw that the sensory motor activity increased significantly in the sensory motor area and in the parietal area and in the left occipital and parietal region. And we then associate that with the corresponding improvement on cognitive functioning, social engagement. We also had there was a small cohort of people who were duly diagnosed with Parkinson's and dementia because the group in Texas solicited subjects from the movement disorders regional clinic downstairs in the hospital. So they got a number of people who had both Parkinson's and dementia, and the caregivers and the subjects with Parkinson's reported significant changes in sleep quality within a week or 10 days of starting the treatment. Their motor activity improved, their social engagement improved, their facial expressiveness improved. There was a lot of that kind of improvement, but we were focused on the dementia symptoms. So we're working now to take some of the data that we collected from an earlier Parkinson study and put that together and get that out as well. But this was really an exciting thing to see. So we're seeing now recent publications that are supporting this idea that quantitative EEG can be useful in differential diagnosis for different kinds of dementia, especially in terms of, looking at decreased anterior and posterior alpha coherence, right? That coherence, that connectivity. And we're seeing that very, very prominently in the data and in the clinical work that we've done, that the hypocoherence significantly increases as people progress in dementia, and that there's a decrease in the left temporal parietal occipital alpha coherence in vascular dementia. I don't have a lot to say about that because I very, very infrequently have been working with people with vascular dementia. It's been primarily probable Alzheimer's, frontotemporal, and primary progressive aphasia that we've been working with, as well as people with traumatic brain injury, but that's a different conversation as well. So I've been working with this device for now 13 years. And one of the things that I've always wanted to be able to do was to modify the pulse rate of the cognito light. And that's just not something I ever succeeded in getting Gordon to do. And okay, so I went and found a company in China that was willing to modify a device that they were already using for photobiomodulation. And I got them to make this device with the 1070 nanometer wavelength. And so that's what we've got over here. The idea that I had, and what we're going to be coming out with in January, is a device that will allow for standard protocols for things like attention, concentration, relaxation, and focus, or having more energy. So there'll be standard protocols like that that people can just use, and that's it for wellness. But if people want to move into a more clinical focus, and clinicians want to start using the device for combining photobiomodulation with neurofeedback, then they can apply and get a passcode that will take them into a whole other set of parameters that can be selected with the touch screen. So everything that you're looking at is basically what the touchscreen graphics will look like. And what you'll be able to do is select which area, front, back, left, or right, in the helmet, right, you want to activate. You'll then be able to set independently whether it's on or off, or what the pulse rate is, and what the intensity is from low to continuous wave. And you'll be able to do that through a protocol that goes for a couple of minutes, but you can set the protocol for a few minutes. Depending on what you want, you can run through an entire protocol of different wavelengths, different arrangements, you get the idea. So it's going to leave a lot of variability and a lot of opportunity for the clinician to develop a protocol in conjunction with the neurofeedback training. So these are the parameters for that device. And just in terms of comparisons, this is just to give you an idea that the V-Lite has either 10 hertz or 40 hertz at the moment. I know that they're coming out with a product at some point that'll have variable pulse rate, and that's terrific. But at the moment, we're going to be offering this one that is not something that's portable. It is going to be plugged into the wall, but I think it has a lot of capability, and I'm really excited to see how clinicians can begin to work with this technology as well as with patients at home. So basically, the new unit is going to have this 4-quadrant capability. It's going to have pulse frequency control from 1 to 20,000 hertz. It'll have a duty cycle from 25 to continuous wave. It'll have 4 levels of stimulation, and we can cycle through those protocols depending on what the needs of the people is. And this is the commercial for this talk. So these are the people I'm working with at Neuronic. And that's all I have to say at the moment.
Thank you so much, Marvin. And really an interesting talk, both because of your experience in neurofeedback and how you applied that experience to PBM and closed loop. So I have a question and about intensity, irradiance. Is that something that in your device can be modulated? Because I think when you talk about intensity, it seems like more a duty cycle.
So it'll be the duty cycle.
Okay. And also I was curious about how did you come up with the upper hand in terms of, I should say upper end, in terms of frequency of pulsing? I thought it was 20,000 hertz or?
That's what the manufacturer was selling.
Okay.
I don't actually see a point to it, but that is what the controller is capable of doing. Got it. It's just I'm giving the specs of the device, but in terms of what we do, we're never really going over 50 or 60 hertz at this point.
Okay. If you want, you can stop sharing so everybody can see each other, and I definitely. It's open to.
How do I do that?
To discussions. I guess.
Stop sharing?
Yeah.
Like that.
Here you go. So I'll open it to others as well.
Oh, great. Well, this is terrific. Okay. So I can move you guys up to the bigger screen. I put the chat in there, but I don't think we really need the chat because we're all here. So that's great.
And also, I was curious about the consulting piece. So is that a fee-for-service model, or how does it work? You said Quiet Foundation is consulting for other providers that are willing to incorporate PBM in their practice, and how is that working?
It's kind of like a clinical supervision process. So if people have cases, we can review the cases with them and go over the way we might approach it or the experiences that we've had and do it as standard case consultation. Though some people have wanted us to help them integrate neurofeedback or integrate photobiomodulation into the practice. And that's when we start talking about how do you actually combine the two technologies. So some people are used to using photobiomodulation, especially chiropractors and people involved with laser therapy. They want to then include neurofeedback. We can work with them around that, or the other way when people are doing neurofeedback and then want to start including photobiomodulation, we'll help them figure out how to buy the equipment, get it set up, and how to become proficient.
I'll see if there are any questions.
And Marvin, do you have a way to verify the LED output of that helmet you have there?
Oh, you mean because it's from China? Yeah.
Well, from anywhere, which is where I'm always worried when devices are not got. I know that for every watt of light you produce, you also produce at least 1 watt of heat, if not more. You'd be very lucky to have a 50% efficiency. So you got heat, and therefore you need fans, and you also need metalwork to take the heat away. And when you have a device without a heat sink, then
the issue, I hear what you're saying. This has only 256 LEDs. So the heat production is significantly lower than the 900, where there are fans on every array.
Yeah, you could have one LED that would be hotter than all of it, just depending what the power is. So it's related not just the quantity of LEDs, but the power of each LED.
I hear you. Yeah. At this point, we're looking at about 5 milliwatts. So we'll have to really look at that. I've been working with the manufacturer, and I'm also working with other manufacturers here in the States to try and come up with a more reliable way of manufacturing the device.
I think we should all be concerned about whether the effect of hair and or patients with a lot of hair with a lot of dark hair particularly, or versus no hair, it's very much going to change the amount of light that reaches the scalp, let alone finds
make any clinical difference. Yeah.
Yes.
We are talking about offering the head shaving device for creating baldness.
Yes.
This is the part where you're supposed to smile. Yeah. No, I think we're going to have to work with people around, either they're going to have to use their judgment, but also having hair. Yeah, we use mist. We've been misting with water to help with that some, but I've asked people to get a haircut like yours.
Yeah, there you go.
You're pretty good. And
yes, let's try getting some PBM on my head then.
So I'm curious about also neurofeedback, and so integrating neurofeedback or not. It seems like there is you're hoping to have a feedback loop from EEG sensing, but it's not clear if this is just in your research or it's also in the kind of company device-based intervention.
Oh, I'm sorry. Can I go back to sharing?
Of course.
Let me see if I can do this. Where's the share feature?
It's a green button usually.
Yeah,
I know. I'm
wherever
looking.
you have that.
Oh, I
bar,
see what's going on. You guys, I put all of your pictures over the green button. I've got it. So that wasn't supposed to happen. Okay. So this capability of left and right will be able to train. We know that by entraining with the light, we can stimulate the EEG to produce specific frequencies. Lou Lim and I showed that at ISNR like 4 years ago. But what we're looking at now is that you can differentially stimulate the left hemisphere and the right hemisphere at different pulse frequencies, and thereby stimulate coherence improvement is what we're expecting to see, as well as stimulating frontal or occipital. We can stimulate the production of or the reduction of amplitudes in those different regions of the brain. Where we want to end up, and what the goal ultimately is to then take the data from the quantitative EEG and other biometrics and have that drive the light stimulation with an algorithm that's driving z-scores that will be produced towards 0. So we can optimize the change in brain state by using the different kinds of stimulation and have that in an integrated helmet type device.
And that makes a lot of sense. Thank you for
yeah, that's where we're going to end up. So I mean, we're about 2 years away from that. I would say we're working with Santa Clara University and their biomedical engineering group on how to build the algorithms for that. But we know now that we can stimulate amplitude changes, either increased or decreased, depending on the stimulation in those areas of the brain. So if we know, which we do, that there are coherence deficits, we can then entrain improvement in the coherence by stimulating the proper back and forth between the hemispheres. Because we've seen that there's an almost across the board regression in the algorithm that the brain is using from bilateral to homolateral processing whenever there's trauma in the body, in the system. So when the trauma is significant, there's a regression to more homolateral processing, which is that early neurodevelopmental stage from like 0 to 10 months when the corpus callosum hasn't fully populated with neurons. And after that, you get more bilateral processing because you've got more bilateral motor activity, which stimulated the production of neural connectivity. But that's where we're headed.
So I just had a question, because looking at this, to me from a neuroanatomical standpoint, these are pretty rough, large areas to be applying stimulation to, and obviously it's all going to be cortical. So how do you deal with coherence with subcortical regions and getting that information when that's really hard to do on a QEEG? Whereas with other types of MRIs, resting state, things like that, you could get more information about connectivity and coherence and synchronization of regions that would actually tell you more.
Agreed. The opportunity that we see is to have the QEEG in the helmet, the electrodes, and we would be getting surface measurements and be able to use Loretta, and SW Loretta is our goal, to work on getting more of that deeper region of interest capability. Again, this is something that we're trying to offer to people that they can use at home. This is absolutely phase 1 of at least 3 or 4 phases, Marnie, I completely agree. But we're seeing that we can get clinical improvement with some of these kinds of surface treatments. And yes, agreed, we're going to need to use those other measures for the better understanding of what it is that we need to be doing. The algorithm will improve, with those other kinds of deeper measures, and we'll just have to wait until we can get that kind of information and build
So at
it.
some point, it would be really useful to kind of compare and look at
absolutely
across the different modalities, because I really think you're missing out when you need to be focal in some cases, and maybe not so much in other, depending on the neurodegenerative disease also.
Right, and certainly, and if you've got brainstem, I mean, NeuroGuide and some of the other software programs are working on understanding and developing Loretta neurofeedback for the cerebellum at this point. So we might be seeing the ability to train the cerebellum in the not too distant future, and that could be built into the kind of training protocols that would be used in this process. Fair point.
Thank you.
I had a question. So you went to China. Can you tell me where in China you're getting your helmet?
Suzhou.
Suzhou.
Oh, you want the company?
Well, no, I was interested in the company and the place. I was just curious where.
Oh, Guangdong.
Guangzhou or
Guangdong.
Guangdong. Is that close to Hong Kong, or is that?
I think it's closer to Shenzhen.
Okay. Well, in any event, I did have some questions. I was curious. You mentioned that you are interested, or you've been treating primary progressive aphasia in your office. And, you know, there's 3 subtypes and so on. We don't have to get into too much anatomy on that. But I was thinking that, you know, you're primarily going to be treating the left hemisphere only in that particular condition. So I didn't know if you wanted to comment about that. And then I'm wondering, with this new helmet, will you eventually be able to get a left frontal only and, you know, right frontal
I'm
only?
sorry. Yeah, you can. Yeah, you can still see the graphic, right? So
yeah.
You can, the checkbox is what will turn on or off that area.
Yes.
So you can turn on, you could turn off everything but the left. And,
okay, but your left is not your prefrontal cortex. It's not.
Oh, I see what you mean. I see what you mean. We would probably want to then be able to segment in a future version of this, the specificity of the stimulation is going to be related to the 19 or more electrodes, so that the targeting of the area is going to be much, much more specified by what's going on in the overall QEEG data. So yes, it's not going to look like this in the end. It's going to be much, much, much more specific.
So I'm just thinking that language is in the left hemisphere. And if we're trying to work in the early stages, especially, well, we'll see what your QEEG comes up with. But I would think you would want to have, even with your current sort of prototype, you would want to be able to turn on the left frontal, left prefrontal, however you want to talk about it, only, along with your left side, which you have here, and in your left occipital. But then your back right now is still just a horizontal, both hemispheres, and off we go. So I was curious about that.
What we could do is block out, like manually put something to block out the right side of the front in the helmet.
You could try that. Yeah, you could try that. And I went, okay, well, I'm sure it'll get better as you move along. I was also wanting to mention that in language cases who have primary progressive aphasia to begin with, somewhere in the left hemisphere, you know, it could be left temporal pole, or, you know, left frontal lobe, or left posterior sort of parietal. And so the issue is that when we worked with stroke patients with aphasia and they only had left hemisphere stroke, we learned the hard way that if we treated both sides of the head simultaneously, we made them worse. Okay, so they got worse.
Right.
And one of our big problems we also learned was that at the very vertex of the head, at the supplementary motor area, we were working with the, the 2-inch diameter Medex Health LED cluster heads. And that was really not a good idea to put simultaneous left-right supplementary motor area stimulation.
I'm curious, did people report any experience of night terrors?
No, Paula.
Okay.
And I know these cases. No, they did not at all, but their naming got worse because when you've got damage in the left hemisphere, I don't care if it's stroke or primary progressive aphasia, but we know more about stroke.
Right.
The way the other hemisphere tries to take over, it's overactivated, and we learned all this through transcranial magnetic brain stimulation, working with Alvaro Pasquale for 15 years, whatever. And so we learned the hard way that we never want to treat both sides of the head, at least in our experience, with a stroke patient with left hemisphere stroke and language problems, because you're just going to make them worse because this other side is already overactive. So the best thing is, you got to pick a side. With transcranial magnetic stimulation, you can bring down this overactivity on the right side. There's no damage there, just overactivity. So you use TMS where you would inhibit an area over here. Mm-hmm. And now in stroke patients, what you really want to do with your light therapy, as we learned, is just stick to the left side, the left perisylvian, and don't even try to treat at the top vertex of the head at all. Not on the left, not on the right, and not simultaneously left-right, because you can't separate it. Those two left and right SMA areas are so close together, you're going to get, carry over to the other side. So my advice is just stay away from the vertex.
I agree. And one of the nice things about this is that you can slide it over and you can block out whatever you don't want to get through.
Yeah, because you'd want to block out the supplementary motor area.
Yeah, oh, absolutely. So thank you, because obviously this is a work in progress. What we have found with stroke and the PPA people is that when we did neurofeedback coherence training to improve the interhemispheric communication, we saw a symptomatic improvement as well. But we definitely stuck to the left side with the photobiomodulation.
Oh, okay. Well, that's good. And you didn't go all the way up to the vertex then? No.
No, and we were mostly focusing on neurofeedback and using,
Did you publish that paper?
What I just said?
The stroke patients. Did you?
Oh no, it was in the clinic. It was just working.
Oh, so we can't look at it. Okay, I was just curious because I don't know EEG and stroke. We only know functional.
There's a fairly significant literature to look at in terms of neurofeedback and stroke.
Yeah, there probably is. I just don't know about it. Can I ask one more question? When you were I assume you went to the factory in China? Is that correct?
I didn't go to the factory.
Oh, no. You did not visit. Okay, so I was wondering if, or did they? Well, okay. Have you been to China? Did you go see any clinicians in China who are using?
Not yet.
I see. Okay, because I was trying to find out what's going on in China. In other words, do they?
Well, there's this virus.
Pardon me?
There's this pandemic, and
yes, travel's difficult.
We can't go anywhere yet. We can't go anywhere yet.
Yeah, I understand. So, I was just wondering.
Yeah, I have a 14-month-old granddaughter, which is why I sound this way. This was my first gift from her, and I'm the nanny of record on Monday.
So, congratulations, that's awesome. I have a question however on neurofeedback, and so I was curious, what have you noticed when you use PBM and neurofeedback as opposed to PBM alone or neurofeedback alone?
We've certainly seen that I've seen that the maintaining of the gains is increased when you combine the two, and that's what we're after. That the increase in the blood flow, the increase in the oxygenation, the increase in the decrease in the inflammation, all are to the good. But then if you repair the network connectivity and renormalize that, then you're going to get a much better result and may be able to maintain those gains over a longer period of time. We definitely see this as a vitamin more than an antibiotic. So it's people are going to be doing this, they're going to be doing it pretty much forever. But I think that we can get, but we can get people who are less compromised now to start thinking in terms of prevention. They can start using neurofeedback as a way to optimize their performance in general, but at the same time, reduce the likelihood of future decline.
So kind of aging population prevention. Mm-hmm.
Right.
Okay.
That's what the paper that just came out of Durham is supporting, to my way of thinking.
We are towards the end, and maybe we can try to finish 5 minutes earlier so that people can get organized and get back to whatever it's in their agenda. But if there are any comments or any final questions, we can stay on for a few more minutes.
Hi, yes, Marvin, I've got a question for you. I mean, in addition to, I'm a collaborator from Taiwan, collaborating with Paolo. So you did mention precisely the location and the dosage of this device. And my question is, have you recommend a certain time for the patient to use this helmet?
Oh, thank you.
Following this question, does the time matters regarding their, I mean, if you have measured any sleep parameters, so does the time influence their sleep parameters?
We're very conservative about how we dose, and we're working with the idea of start with 2 minutes and notice whether you have any kind of overdose reaction over the next 5 to 10 minutes. And any kind of overdose reaction, sleepy, dizzy, agitated, headache, congestion, anything like that, stop and don't do anything for another 24 hours. And basically titrate the dose up, but don't go over 15 minutes at any point, and do that maybe once or twice a day. However, I've had people with chronic pain conditions and chronic insomnia conditions where we've had to start at 2 minutes, and really what we found was effective was 30 seconds. So we had to back the other way and only do 30 seconds. And when they did 30 seconds, right, people with 20-year histories of pain were saying, I feel 80% better. And I it was just a shock, but it started to make sense because, as James has said before, that less and sometimes more. And it's very important that we recognize that, American capitalism aside, more is not always better. So I just want to, support the idea that you've got to dose very strategically and with a real understanding clinically of what's going on with the patient. So I don't recommend standard dosing at all.
And David and Marvin, I have a follow-up question on this. I'm actually interested in what were the clinical indicators that led you to decrease the dose? Was that tolerability, or was it just lack of effect?
Yeah, when somebody's sensitivity, if you start increasing the dose and their sensitivity is either rapidly increased or they basically shut down and there's no response at all, then we go the other way. But there's also the history, there's, looking at the clinical history, that people's sensitivity, if they come in saying, I can take a quarter of a baby aspirin and it knocks me out, we're not going to tell them to start at 2 minutes.
Right. Thank you, then.
Are we there?
Okay, so with that, I think we can probably wrap up. Thank you so much, Marvin. I really like all your clinical experience to inform your talk today, and dosimetry is one of the arts of PBM still, and maybe one day will be something predictable over hard data, and we definitely want to get there.
I think that the QEEG can help with moment-to-moment monitoring of that. I think we can also do the analog to event-related potentials with stimulation at different frequencies and look at what happens to the QEEG z-scores and start using that as a framework for developing an intervention strategy with PBM that's much more targetable in terms of dose.
Absolutely. Thank you all. Thank you, Marvin. Nice seeing everybody. Bye now.
Bye-bye.
Thanks.
See you next time.
Bye.
Bye-bye-bye.